Hi, everyone. My name is Hannah Young, and I am the Director of Communications for the Scleroderma Research Foundation. It is so exciting to see you all here, and thank you so much again for joining. Now, I am honored to introduce Dr. Ami Shah. Dr. Ami Shah is an Associate Professor of Medicine and Director of the Division of Rheumatology at Johns Hopkins University. She also serves as Co-Director of the Johns Hopkins Scleroderma Center. Dr. Shah's clinical practice is focused on the broad spectrum of patients with scleroderma and related disorders. Her research has focused on the link between scleroderma and cancer, as well as on developing novel methods for estimating the risk of complications and disease trajectories in scleroderma. Dr. Shah is a graduate of MIT and the Johns Hopkins University School of Medicine. She completed her internal medicine residency training at Stanford University, and then she returned to Johns Hopkins for her postdoctoral fellowship, where she also earned her master's in health sciences and clinical investigation at the Johns Hopkins Bloomberg School of Public Health. And with that, I'll go ahead and hand it off to Ami. Thank you.
Thank you, Hannah, for that kind introduction and for providing me with the opportunity to talk about our work developing personalized medicine strategies in scleroderma. As you all know, scleroderma is a heterogeneous and highly variable disease. It consists of various well-defined subtypes, and there are common clinical links between these subtypes, but patients can have unique features, a unique disease course and expression pattern with many different potential outcomes. One of the things that we as rheumatologists try to do when we're seeing patients with scleroderma is to classify the extent of skin thickening a patient has, because we tend to think of patients who have the diffuse form of scleroderma as having a higher risk of fibrotic or scar tissue related complications. And that's shown in the top panel of images of a patient with diffuse scleroderma who has extensive skin thickening, joint contractures, and the development of interstitial lung disease. Whereas we tend to think of patients with limited scleroderma as having more vascular or blood vessel related complications of the disease. And that's shown in the bottom panel of images of a patient who has exuberant telangiectasia on the skin, a patient who has had severe Raynaud's phenomenon and ischemic digital loss, and a patient with pulmonary hypertension. Yet we know that this simple construct between limited and diffuse scleroderma does not tell the whole story. We can see patients with diffuse scleroderma who have severe Raynaud's phenomenon and pulmonary hypertension, and those with limited scleroderma who can have clinically significant interstitial lung disease. And indeed, there can be tremendous variability within these subsets. So we can see patients with limited scleroderma who have a very benign clinical course over time, those who have overlap with other autoimmune syndromes or have interstitial lung disease or pulmonary hypertension. And within diffuse scleroderma, we have patients who have milder skin involvement and those who can have a rapidly progressive course and a higher risk of kidney involvement and heart disease. So one of the things that we're trying to do as we see patients with the disease is to identify a patient's phenotype. So what is a phenotype? A phenotype is an observable characteristic, and we're doing this by looking at several parameters. So one is the skin subtype a patient has. Do they have no skin involvement, limited scleroderma, or diffuse scleroderma? We're looking to see whether they have the presence of organ involvement across a variety of organ systems and whether there's severe organ involvement. And we're also looking at the type of autoantibody a patient makes. And the thought behind this phenotyping process is if we can sufficiently phenotype a patient, we can better predict how well someone is likely to do, who is at higher risk for different types of scleroderma complications, and who may respond to certain medications or need additional therapies. And over time, the goal is that if we can combine phenotype with other measures that we're learning through research studies like genetic information or biomarkers in the blood, we'll get more meaningful answers. One of the tools that's very helpful to us clinically is to test for scleroderma-specific autoantibodies because we know that these associate with very distinctive phenotypes. There are a variety of autoantibodies, and I'll just speak to the three most common ones today, but we know that patients with anti-centromere antibodies are more likely to have limited scleroderma, and they often have features of the CREST syndrome. patients with SCL70 or topoisomerase I antibodies are more likely to have diffuse scleroderma, and they have a higher risk of interstitial lung disease. And patients with RNA polymerase III antibodies can have a more explosive onset to their disease with diffuse skin thickening. They have a higher risk of kidney involvement, which we call renal crisis, and a higher risk of having cancer around the time that their scleroderma is developing. While these are very useful tools, even within an autoantibody subgroup, we still can see variability. So to give you an example of this is data from 289 patients with scleroderma, all of whom have SCL70 or topoisomerase I antibodies. And what I'm showing you is these patients' lung function trajectories or disease course over time. So in the green, I'm showing you the forced vital capacity, and in the red, the diffusing capacity. These are measures from pulmonary function tests. And we can see that there is a group of patients on the left who have a very stable disease course over time, and a group of patients on the right who have a progressive decline in their lung function. And when we look at the beginning of these patients' disease, we're really not good at predicting who's likely to be stable and who's likely to have a progressive course. We're able to get it right about 40% of the time, and that just illustrates that there's so much more work to do to identify biomarkers that could help us better predict a patient's likely disease course at the beginning of the disease. So our challenge is that this is a very heterogeneous or variable disease that consists of several distinct phenotypes. We talk about the 15% rule in scleroderma, which is that various complications across a variety of organ systems can occur in about 15% of patients. We have tools like autoantibodies that can strongly predict phenotype, but they're still imperfect. We have the challenge of timing, that is that clinical events can evolve over time, and there's also variability in terms of how patients respond to treatment. So let's take a step back and think, how do we actually make informed medical decisions in patients who have a highly variable disease? So if I think about what I'm doing in our Scleroderma Center clinic when I'm seeing a patient, I'm trying to integrate information across multiple parameters and multiple organ systems for a patient. I'm trying to account for not only where they are now in their disease and not only where they've been at the beginning, but the entire disease course in between. And I'm trying to adjust for these risk factors that may associate with a higher risk of different types of complications, such as whether a patient has limited or diffuse scleroderma or their type of autoantibody. And what this does is this results in an estimate that I'm generating of a patient's health state and their risk for complications and their need for high-risk therapies. The challenge with this type of thought process is that it's really informed by a provider's prior experiences caring for patients who have had a similar expression of disease. And so this is not a thought process that can be easily replicated, especially when you're thinking about taking care of patients with a rare disease. So how could we neutralize this complexity and get closer to a vision of personalized medicine for patients with scleroderma? We've been fortunate at Johns Hopkins to participate in our university's personalized medicine initiative. And through this, we've been thinking through a series of questions. First, how could we harness knowledge that we've gained from seeing a large population of patients with scleroderma to improve pattern recognition and risk estimation across multiple organ systems? Is there a way that we could do it efficiently at the point of care and at the level of the individual patient? Could we do it in a way that addresses questions that are meaningful to our patients? Our patients are often asking us, what is the state of my disease? What is my long-term prognosis or trajectory? And how do I compare to other patients you've seen with scleroderma? And could we do it in a way that would generate a useful tool that could help rheumatologists and patients with scleroderma, regardless of where they get their care? So I want to share with you a 3-step process that we've been working on to develop tools for individualized health. The first step is to develop a data visualization and analysis tool. We've called this tool Patient Insight. And what Patient Insight does is it illustrates an individual patient's trajectory or disease course across multiple organ systems. This is harnessing data from multiple sources, including our electronic medical record system. The tool is designed to be interactive, so it's not only showing a patient's disease course across multiple organ systems, but we can see this patient's disease course relative to a whole population of scleroderma patients or relative to the subgroup of patients who is most like this patient. So for instance, if a patient has limited scleroderma and anti-centromere antibodies, I can compare this patient to others who are most like her. We've designed this tool to be a web-based application programming interface to enable future dissemination where it can be linked into a variety of electronic medical record systems. Now, our goal is not just to show where a patient has been, but to ideally show where is a patient likely to go. And so we've been very fortunate through this precision medicine initiative at Johns Hopkins to work with world-renowned biostatisticians to develop personalized risk estimates for multiple complications. And what this is doing is it's harnessing an individual patient's prior data and the data of the population and the data of the subgroup who's most like this patient, for whom we may already know the outcomes, to improve prediction of future trajectory for the patient who's right in front of us. And our goal is to bring that individualized predictive modeling back into the patient insight tool so we can test its value in a clinical setting. So next, I'm going to show you a video of patient insight, again, just showing you the power of showing a patient their longitudinal data.
In this video, we will demonstrate the functionality of Patient Insight, which is an interactive tool that illustrates patient and population trajectories to improve clinical care in scleroderma. This is a longitudinal viewer that shows a selected patient's data across multiple organ systems. The Patient Information tab displays the patient's demographic and clinical information, including onset date, cutaneous type, autoantibody type, as well as comorbid conditions and disease manifestations. In medications, we display the patient's longitudinal immunosuppressive medication exposure data. And in patient events, we display measured clinical events. We can see this patient had events concerning renal crisis, myopathy, interstitial lung disease, and pulmonary hypertension over the years. Here we can see this patient's ejection fraction and RVSP, where we can assess this patient's heart function trajectory over time. To assess lung trajectory over time, we display lung measures including FVC and DLCO. Here we show this patient's percent predicted forced vital capacity relative to what's expected for other patients in the entire cohort. The yellow lines in the background show the 10th, 50th, and 90th percentile for the entire Johns Hopkins Scleroderma Center cohort. A key feature of this tool is that we can compare this patient to other patients who are most like her. For example, female patients with RNA polymerase autoantibody positive. We can use this core filter function to select female patients with positive RNA polymerase autoantibody, and the reference information will change. And by scrolling through the rest of this page, we can get a snapshot of this patient's skin score trajectory, whether or not this patient had a severe GI disease, BMI trajectory, RP scores, significant muscle weakness, lab results, and disability index scores.
So this tool has now been embedded in our electronic medical record system, and it's been important to us to test whether or not this is actually useful to patients and providers. So we've conducted 2 studies to look at this. The first was a qualitative study where we recruited patients with scleroderma, and we showed them their own data in the Patient Insight tool, along with their data relative to other patients. And we were interested in understanding, does this help patients understand their disease course, their prognosis, and are they comfortable seeing their data relative to other patients? In the second study, we recruited expert rheumatologists who take care of patients with scleroderma, and we presented them with different case scenarios and asked them to assess the case scenarios either with the electronic medical record, which we would consider to be the standard of care, or using Patient Insight. And the clinical scenarios were designed to address questions that come up commonly in the Scleroderma Center clinic, such as, does immunosuppressive treatment need to be started or changed for interstitial lung disease? And should testing with a right heart catheterization be pursued to assess for pulmonary hypertension? So first, in our patient-facing study, we learned that patients felt that they understood their disease course better, had a better sense of what the future may hold, and felt more in control of their disease by seeing the patient insight tool. And I've just selected here a few representative quotes from our patients to give you a sense of what our patients were telling us. So one patient said, "It gave me a sense of my own disease severity and more perspective on that." Another said, "I'm a very visual person, so seeing a graph is very helpful to me. If you would have just told me, I might have forgotten some of what you said, but now I can remember what those graphs look like." Another said, "With knowledge and understanding anything come things that I can be doing better to help myself." And another patient said, "I feel the more knowledge I have about my disease, the more confidence I have. When you have more confidence, you're more in control of the situation." Our patients also gave us wonderful suggestions of how we could improve the tool. So they suggested that we add more information on the directionality of trends in the graphs so that patients can interpret the results even without their doctors. They also asked that we provide more information about their relevant subgroups, how many patients are in it, and what has the future looked like for the subgroup. So for instance, one patient said, "It would be helpful if I could see some sample of other patients as a model or the mean patient to see how their scleroderma evolved. I've been dealing with scleroderma for 14 years, so maybe by looking at someone with 24 years of scleroderma experience, I could see what the next 10 years my disease might look like." That would be enormously helpful because obviously there are gaps that I can't fill because it's in the future. And again, I'll come back and talk about this predictive analytics piece in just a moment. With our rheumatology experts, we found that they were able to look at 7.5 to 10 times more data in 80% of the time when they used patient insight compared to the electronic medical record. And as a result of that, when they recommended a change in the plan for testing or treatment, they reported much higher levels of confidence in their decision-making. And just to give you a few examples of what our providers told us, it's nice to see everything laid out like all organ systems. Usually you just forget, even if it's your own patient, so I'd have to go back to the first notes. But in this tool, I can pull it up in milliseconds. Or another quote, "I felt like I was better able to assess the scope of their disease, not only in recent months, but from onset, which is really cool." And lastly, "I'm very confident because the tool allowed me to refine my diagnosis based on the data provided." So this is just showing you the power of illustrating data in a visual way and aggregating it to make it useful. Again, none of this is about predictive analytics, but even this early step has a great value. Now, our goal is not just to show where a patient has been, but really to make better informed predictions about a patient's likely future state, because this may impact whether or not we do certain screening tests or whether we should be treating with certain medications. So as we've been thinking about how can we make informed predictions about the future, we've thought about how do we go through that clinical decision-making process that I told you about earlier. So first, we think about risk factors that we know are important from population studies. These are things that contribute to our understanding of phenotypes or subgroups, like the skin involvement pattern or antibody status that a patient has. We also want to account for the data from that particular patient, not only the data from this moment in time, and not only the data from the beginning of their disease, but the entire disease course in between. And we want to be able to do this across a number of parameters and organ systems because these parameters often track together, they're highly correlated, and we can draw information from one to inform prediction of another. And lastly, we want to harness data from all of the other patients with scleroderma that we've seen, and especially from patients who are in the same subgroup for whom we may already know their outcomes, to improve prediction for the patient who's right in front of us. So the idea here is if we can combine these factors, we could improve prediction for an individual patient. I'm not going to go into detail today about the statistical modeling approaches that we've been using, but we're simultaneously characterizing each patient's trajectory in multiple organs, calculating the probabilities of multiple critical events in the future, and we're doing this in a way where we can generate real-time predictions as we learn new data. So for instance, if a patient comes into the clinic and I'm obtaining a new skin score and a new pulmonary function test, I want to be able to account for that data in real time and get an updated prediction. So it's important that computationally we design this in a way that enables that. This is just an example of what this type of embedded prediction could look like. This has been developed in a prototype form in an application called R-Shiny. And on the left, we can see this patient's clinical characteristics and antibody status over the time. On the right, I'm showing you a patient's trend in forced vital capacity, ejection fraction from the echocardiogram, and right ventricular systolic pressure, as well as their predicted probabilities of crossing certain thresholds that are clinically important. So let me give you an example of how this could be helpful to our patients and providers in terms of decision making. Here I'm showing you data from two patients, two women who are very similar. They have similar ages, similar type of scleroderma, the same race, and the same autoantibody profile. And what I'm illustrating for you on the left is a patient's right ventricular systolic pressure over time, and we see the same graph for another patient on the right. So you can see that their trends have been very similar. However, for the patient on the left, her predicted probability of developing pulmonary hypertension in the next 2 years is about 14%, whereas for the patient on the right, it's about 38%. So you may ask, why are their predicted probabilities so different when so many of their characteristics are the same? Now, I mentioned to you before that we're often looking at multiple parameters together to inform prediction of a patient's likely risk of developing a complication. And one such parameter that we look at for pulmonary hypertension is something called the diffusing capacity, which we're measuring from the pulmonary function test. And we can see for the patient on the left that her diffusing capacity has declined slightly over time, but for the patient on the right, the degree of decline has been greater, and this patient's diffusing capacity is now at the 10th percentile value for the rest of the scleroderma center cohort. And indeed, patient B underwent a right heart catheterization, which subsequently confirmed a diagnosis of pulmonary hypertension, whereas this has not developed for patient A. There are several steps we need to undertake to be able to disseminate these tools and ensure that they're beneficial for patients with scleroderma everywhere. So first, we would like to externally validate these predictive models with other cohorts of patients with scleroderma to ensure that they're representative of scleroderma as a whole. We're working now to embed the predictive analytics back into the patient insight tool, and we've designed studies to assess whether this is helpful with risk estimation and treatment and testing decisions. A key thing we would like to do in the future is integrate decision support tools. So for instance, if a patient has an elevated risk of a complication, we would like to be able to provide advice suggesting that treatment be started or a patient undergo further testing. Another thing we're working on is incorporating potential outcomes under competing medication choices. So we don't have time to go into this today, but we're doing statistical modeling to try to predict, is a patient more likely to benefit from staying the course or starting drug A or drug B? And what is their likely trajectory under those different scenarios? We're also thinking about ways to develop this as a patient-facing passport. So for instance, it would be very helpful if our patients could access this tool on their own. Say a patient presents to an emergency room, they could share with the doctors there, here's my scleroderma data, my scleroderma passport. Please call my rheumatologist. So these are all of the ways that we're thinking about developing and enhancing this tool over time. So I hope you found this to be helpful in terms of our approach of developing personalized medicine strategies in scleroderma. Our goal here is to use high-dimensional data from patients we've followed over time and new computational tools to try to neutralize the complexity of the disease. And we think this approach can help us achieve a number of goals in terms of gaining insight into underlying disease mechanisms, to identify patient subsets at high risk of different complications, to define which patients are most likely to benefit from different screening and treatment approaches, and to hopefully improve patient outcomes and reduce unnecessary testing. I'd just like to thank my many colleagues at Johns Hopkins who have contributed to this work, as well as support from the Johns Hopkins Individualized Health Initiative, the National Institutes of Health, the Scleroderma Research Foundation, and our philanthropic partners. Thank you so much, and I'd be happy to take any questions you may have.
Dr. Shah, thank you so much for helping us understand a bit more about trajectory modeling and the extensive work that you and your colleagues have done with trajectory lung modeling and how it's going to help our scleroderma patients. We've had a number of our listeners submit questions, and I hope it's okay if I just go ahead and pick about 3, which is about what we have time for. In the first one, our listeners were wondering if they wanted to know a bit more about their phenotype or the clinical group, what factors are most important to learn from their doctor in order to effectively use the modeling tool?
Thank you so much for that question. So, in addition to thinking about a patient's age and race and where they are in their disease course, whether they're early in the course of their scleroderma or further along, it's important to think about their skin type, whether they have no skin thickening, limited involvement, or diffuse involvement. We also look at a wide array of organ systems that can be involved and the severity of that, thinking about the peripheral vasculature like Raynaud's, the GI tract, the heart, the lung, the kidney, muscles, and joints, and the autoantibody type. And so I think factoring all of those things together can be very important in terms of helping us understand a patient's phenotype and their likely future disease course.
Great, thank you. Just following up on that, could this approach be used to evaluate which type of treatment or which exact treatment a patient should consider, or ultimately sort of a series of treatments that a patient might want to consider?
Yeah, that's a really important focus of our research now, is trying to understand how from observational data we can better predict where a patient is likely to go under a series of different treatment options. And this requires more complicated statistical modeling because we're trying to understand a patient's potential course under a treatment compared to what would be likely to happen if we didn't treat. So that type of modeling work is underway, and we're hoping that it will help doctors and patients make better decisions about a variety of options that may be available to them.
Right, great. Thank you. Maybe one last question I think we've got time for. How could studying patient subgroups be used to learn about the potential causes of scleroderma? And if we knew a bit more about how the disease started, would that enable us to intervene perhaps earlier in the disease?
Yeah, that's a great question. So we do think that these phenotypic subgroups are very powerful tools for us to study the underlying biology of the disease, and that if we can define more homogeneous subgroups, the closer we'll get to this vision of personalized medicine in scleroderma. So if we think about one way that we've tried to do this, we've identified that there is a subgroup of patients who have a higher risk of cancer around the time that they're developing scleroderma. And when we studied the biology of that, we were able to find that these patients likely have autoimmunity that's developing secondary to the cancer. And so that has a number of clinical implications. So one, it suggests that people who are in that subgroup should undergo different cancer detection strategies to see if there's an underlying cancer. But it also suggests that in those patients, cancer therapy could actually be effective scleroderma therapy. So those are some ways that we use subgroups to learn more about disease mechanisms.
Well, that is just fascinating and really instructive. Thank you so much. I wish we had a bit more time, but we are at the end of this segment of the Patient Forum. Dr. Shah, thank you so much for joining us today. And for those who submitted questions, apologies if we didn't have time to answer yours live. But the SRF staff will be following up directly with you via email to try to address your questions and answer follow-on questions if those emerge as well. To our audience, thank you so much for joining us today. It's been truly inspiring to see this much engagement, and we are really honored that you chose to spend your time with us. I'd also like to give special thanks to all of our presenters, my fellow members of the SRF Board of Directors, our research committee, and our staff behind the scenes. And of course, I need to thank our industry sponsors, Boehringer Ingelheim, Janssen, Merck, and Gossamer Bio. It's obvious, I hope, that research is our best hope for finding a cure, which is why at the Scleroderma Research Foundation, research is at the center of all we do. Of course, we can't do it without you. It takes a community to tackle such an ambitious goal by working together with scientists, clinicians, patients, industry partners, our donors, our advocates, family, and friends. Together, we will end scleroderma. Thank you all, and have a wonderful rest of your day. Bye-bye now.